Yeah. But if somebody doesn't give a chat, then I don't know how much time is passing in that sense.
Okay.
There you go.
Good evening, everybody. On behalf of the India International Center, I'm delighted to welcome all of you to this webinar, which is looking at musing on the pandemic. So, all of us are, it goes without saying that all of us are living through perhaps the most extraordinary times of our lives. Not just individually, but as societies, as communities, as countries, as nations. And the process of making sense of this while trying to cope with all these difficulties further complicates all of this. There have been myriads of papers, myriads of discussions, myriads of writings, thoughts about what this means both to the nature of the world, how this is going to transform the world, how nothing is ever going to be the same again, and at the same time, how all of this is going to pass very soon and we are going to be back exactly where we were. And the fact of the matter is that, like all stories, all these multiple stories are obviously true. There are many different tellings to this tale. There will be, and there will continue to be. So the way that we are today approaching this is from 2 or 3 parallel but different lenses. And those lenses are basically the lenses of history, the lenses of mental health, and the lenses of inequity or marginalization. So this is not the first pandemic that the world is dealing with. It's certainly not the last. What is it that earlier pandemics have taught us? What is it that we have learned from them, or perhaps not learned from them? What do the mental health implications of this very large event look like? And what is it that we are doing about it? How are we thinking about this? And what are we planning to do with this? And what does this complex phenomena do to life at the margins? Because we are all very clear that all existing fault lines, whether they are economic, whether they are communal, whether they are socio-political, all these fault lines have been broadened, deepened, widened. So both from an understanding, of developing an understanding of what it is that is happening, and of trying to figure out what our coping mechanisms have been, should be, and are, is how we have tried to structure this discussion. So we have a very eminent group of speakers here today to share this discussion with. The first is Professor Sanjeev Jain, who is a professor of psychiatry at the National Institute of Mental Health and Neuro-Sciences. Many of you will know Sanjeev. Sanjeev is a prominent psychiatrist. He's interested in the history of psychiatry. He's interested in molecular genetics. He will be talking to us about the history of earlier pandemics and what they can and should be teaching us. Our other speakers are Vandana Gopikumar, who's the founder of the Banyan and the Banyan Academy of Leadership Management in Chennai. The Banyan, as many of you will be aware, works with homeless and disadvantaged people and tribal communities in mainly in Chennai, but in many other states across the country. And they have been doing a lot of very impressive work, uh, not only during the pandemic, but for many decades now. So Vandana is going to talk to us about her experience and the Banyan's experience in the pandemic. Ratnaboli from Calcutta is the founder of the Anjali Mental Health Rights Organization, which has worked again for many decades with people in mental health institutions and with homeless communities, with disadvantaged communities, mainly in West Bengal. And Ratna is going to share with us uh, her experience and the experience of Anjali in West Bengal, uh, and what Anjali has been doing, mainly what Anjali has been doing during the pandemic. Uh, Last and certainly not least, we have with us Pratima Murthy. Pratima is a professor and the head of Department of Psychiatry at the National Institute of Mental Health and Neuro-Sciences in Bangalore, who is going to talk to us about institutional response. So, the National Institute of Mental Health and Neurosciences, NIMHANS as it is known, is the largest mental health institution in the country, the largest public mental health institution. So, Pratima is going to share with us insights about NIMHANS and how it is coping, dealing with the pandemic. And not only that, Pratima also heads the de-addiction uh, center uh, in NIMHANS. So what this means when looked through the lenses of addiction. Uh, so without further ado, I will now invite the speakers. So may I first invite Sanjeev? Uh, Sanjeev, the floor is yours.
Thank you, Alok, and thank you, everybody who's logged in. Uh, Pleasure to be here in whatever strange circumstances that we are. But I'll be talking about how epidemics have been a part and parcel of life on Earth, as all the organisms, whether it's bacteria, viruses, worms, we all live in cooperation and competition. And human history itself is as much a history of epidemics as it is of socio-political change. Increasing population over the last 500 years and the spread of globalization and colonization spread infectious disease all over the world. We imported syphilis from South America, gave them smallpox in return, and all the diseases of cholera, malaria, all these, and even AIDS spread throughout the world over the last few hundred years. And human society has changed its behaviors and the ways to handle disease accordingly. How epidemics start and spread, however, became specifically more understandable in the last 200 years once we started applying instruments like the microscope and cell culture to everyday life of doing these sputum cultures, examining body fluids under the microscope, etc., etc. And even the drinking water and the food and the very air became subject to the medical gaze. Lots of this early work on how to identify the bacteria and the infectious disease was actually done in India, whether it was Robert Koch in Calcutta in the mid 19th century, Ronald Ross on malaria, Haffkine on the plague. So, all the initial work on how to understand the spread and the control of epidemics was done in India. And methods to ameliorate this, like inoculation, were also attempted during the colonial period and often resisted as an intrusion into our so called private life. However, the 100-year ago epidemic of the flu, which was caused by a virus, and the virus we now know was influenza virus, but at that time we didn't even know what viruses were, was perhaps imported to India with the returning soldiers from the First World War, spread rapidly from Peshawar to Mysore and from Gujarat to the Naga Hills. So the whole length and breadth of India was affected, so much so that the soldiers fighting the Naga insurrection of 1918 were also affected. The infection spread along railway lines as the workers scrambled to get home from the industrial towns of Bombay, and all along the Bombay to the Grand Trunk Road, infection spread. And they died in large numbers in the villages because they had poor facilities, unlike when they fell ill in the first phase in Bombay, where hospitals were set up and public facilities were established. Once they reached the villages, they just died in large numbers. Charity and concern were very evident in the first few months, but proved powerless in the long term to stem the tide of death and misery. India lost almost 20 million people. There was no increase in population in the census of 1911 and 1921. So an entire decade of population growth was wiped out. There was even a small decrease. The poor control of these epidemics in India, the high mortality of Indians in general, and the short span of Indians compared to the lifespan of the ruling power, that's Great Britain, which had been widening ever since the British took control, forced the colonial government to plan better healthcare. And they responded by setting up health institutes and research stations, but did not invest in public health. This was quite different from the experience in Europe, where investments in public health, in proper sewage, clean water, rebuilding urban and rural housing, and providing universal healthcare proved the bedrock of controlling and understanding epidemics. Some attempts were made in the closing years of the colonial rule, but the expense involved, the administrative complexity, just confused everybody. And after independence, the Indian Medical Service itself was dissolved as healthcare was devolved. Public works engineering was diverted to everything else. And therefore, it is very imperative that the science and the history of infections and how humans respond is understood and shared by the community. In the absence of this understanding, most interventions may end up being seen as being coercive and engender even more distress and despair, as also fear and suspicion. As Phipson noted a century ago, the provisioning of care, making sure that the society cared, was the most successful way of communicating that those in control actually cared for the people that they ruled over. Thank you very much for your attention.
Thank you. Thank you, Sanjeev. Thank you very much. May I go on to the next speaker? May I invite Vandana to share with us the experience of the Banyan during these truly interesting times?
Thanks, Alok. I'm actually going to take off from where Sanjeev ended. Sanjeev mentioned that one of the most critical things or critical lessons from the past pandemic was really the fact that state and society had to act together and respond to the needs of those who lived on the margins. Now, 100 years have passed, and we do know, and I learned this from Alok and Sanjeev when we were talking earlier, that about 61% of those most harshly affected in the 1918 Spanish flu were low caste Hindus, right? And the 7% or so least affected were the Europeans. Now, just substitute that with persons who are living on the margins. And here I'm talking about persons who are homeless, persons from indigenous groups, and persons who live in low-income households. And nothing much has really changed. So like Sanjeev mentioned, I think there was a lot of traction, a lot of investment to health, a lot of focus on universalization of healthcare. But unfortunately, it didn't sustain over a period of time, neither human interest or empathy. And this is something that I think we constantly need to remind ourselves about. Talking about the Banyan experience itself, working with homeless people, now there are supposed to be 1.75 million homeless persons in India, and I think it's a gross underestimation. But of the 450 people whom we have serviced within the Banyan, I think they have pretty much been safe, and we've tried to do everything possible in our might to ensure that their life has continued uninterrupted. Persons of the streets continued to sort of live homeless. Their plights, the impact of the pandemic on them has been fairly significant. So as part of our outreach program, we serviced about 100 over the past month and a half. And the pathways really, so 10 of them ended up homeless, 10% ended up homeless as a result of the pandemic. About 30% of them ended up homeless as a result of mental health issues. And about 60% of them as a result of family conflict, violence, lack of health access, and unemployment. Now, I think all of us are reminded the minute that we talk of the pandemic of the millions of people who were just walking back home as a result of loss of livelihoods. I think the homeless community, as a result, has been hugely affected because many of them are employed in the unorganized sector. And unfortunately, their jobs were gone and there was no housing stability. Now, what has been the impact? While on the streets, about 48% of them indicated that they had experienced one or the other form of violence, sexual, physical. Their support networks, now this is most important, disappeared overnight during the lockdown. Temples, churches, mosques, small eateries, tea shops, and people on the streets, these were essentially their support network, their social capital. All of that was gone, and they were alone. So the sense of alienation and the sense of also not being part of social worlds of the majority of our civilization was something they experienced acutely. They were also the last to sort of be serviced, and therefore benefits reached the homeless the last. In terms of irregular communities, these are typically persons from indigenous communities who live in Kerala and Tamil Nadu. Again, about 60% of them had lost their wages. So they were living with absolutely no access to money, and therefore there was no cash fluidity to buy vegetables or to buy soaps to wash their hands. When we talk about washing hands and accessing private toilets and isolation, two communities, both the irregulars and those in low-income households. Clustered housing, I mean, there are 10 or 11 of them living together in a house. In the irregular community, in the hamlets that we work in, there are about 50 accessing one toilet. Very often there is no water. When there isn't sufficient money for food, forget buying soaps and washing your hands. So the whole notion of adhering to public health protocols was something very remote to both those living in low-income households, and that's typically, in my opinion, 80% of India that lives on $2 or less, and to irregular communities, which is about 10% of our country, right? So that's really majority of our country. Now, amongst those who belong to the indigenous groups, a huge problem seemed to have been access to general health care, because during the initial period, the public health centers were closed. But worse still, transportation was a huge issue. And because they live in remote areas, for them to have to travel in normal times is bad enough. But during this period, it was particularly difficult, and therefore their health suffered. Children, fortunately, 75% of them could continue in education, but 25% had to drop out. And particularly because one of the key reasons really was because they had to take to work and earn some monies so the family could eat. Now, in the case of the ultra poor, about 800 persons, that's the number that we serviced, about 50% of them had lost their jobs. Extent of domestic violence or intimate partner violence was really on the rise, and therefore women suffered a lot. The attempts to die by suicide had increased. Children, unfortunately, were witness to this. And therefore, when we spoke with 200 of the kids that we work with, they indicated that for the first time, they were exposed as much as they were, because otherwise they're away for a large part of the day. The woman, the family is away, both the husband and the wife are away for a large part of the day. But here they were all living in together. And therefore, the child was exposed to violence. The child was also acutely aware of the financial insecurity. And yet, in most of these cases, the children did say that they had access to 3 meals, and they did have to transition to online education. Many of them, of course, didn't have access to the internet, but they didn't find that too much of a problem. And despite these adversities, felt somewhat hopeful. Now, there's a lesson to learn there, and that's something that we have to dig a little deeper. So typically, I mean, it's just 5 minutes, and therefore, the lessons or the takeaways for me. So when we asked these individuals, when you say you're eating 3 meals, or because many of them said, yes, we have access to food, yes, we have access to toilets. What really is it? So several of them said that, yes, we have access to food, but it's probably water and rice, or it's an onion and roti, if we manage to get it. And toilets is really 50 of them sharing a toilet. So we have, in my opinion, normalized deprivation over the past 100-year period, where it is all right for one to think that eating rice and water or having to give up on your meal just to survive, just to ensure that your kids eat, is something that is your lot, that you have to simply accept and be resigned to. So that's an issue. The second issue is that relief was associated with identity cards, and both the irregular community, so members of the irregular community and the homeless persons, are typically those who do not have access to these identity cards, and therefore they were the last to access relief measures. So this cannot be a part of any relief program, regardless of your identity or the lack of it. I think relief has to be absolutely forthcoming. And I'd end by saying that health and education really are public goods. And if we haven't learned that these inequities can have huge impact on not just these persons who live on the margins or on socially disadvantaged communities, but on us as a society, where we are comfortable over 100-year period and beyond with the majority of our population living in such penury and being deprived of their basic rights, I feel that we have to challenge these inequities with a strong sense of determination. Thank you for your attention.
Thank you, Vandana, for that compelling and complex message. We'll come back for a discussion on that. May I now invite Ratnaboli Ray, who works at the Anjali. Ratna, as somebody who's worked with the state in health and mental health and developmental issues for a long time, and somebody who's had both a collaborative and often confrontational relationship with the state. What has your experience been in the last truly strange times, in the last few months?
Thank you, Alok, and hello to all the invisible audience who have logged in. We can't see, and this is perhaps the challenge that a pandemic has brought in, that we can't see and who we are invisibilizing. And one such invisible community that I'm going to talk about are the ones who live in mental institutions, in public mental institutions throughout West Bengal. So when the first lockdown was announced, and I made a visit and I was talking to them, we had several roundtables with the residents there. And the first thing was that they were extremely jubilant. They said, good, now we have been living under perpetual lockdown. Now you will understand what it is to live under lockdown. So that was a very profound, I think, statement which gave us an opportunity to reflect as to what it means to live in lockdown with finances, lockdown in relationships, lockdown with our disabilities, lockdown with our abilities, etc., etc. And I personally feel that this lockdown has unleashed a tyranny of ableism and a tyranny of ageism. And I'm going to borrow what Vandana was saying, that the public health mantras, which has been disseminated and which has been communicated, it clearly means that if you are healthy and if you are able, you are going to survive. And if you are in the margins, then you really do not matter. And why I'm saying this? Because the access to protective kits, access to safe, clean water, access to information, it was all very scarce. I don't know what the scenario would have been if a CSO like Anjali was not present in all the mental hospitals. And I also saw that this inaccessibility actually deepened the marginalization that we are talking about. The other thing is the feeling of disposability. Many of them spoke to us saying that how they feel that they can be disposed of very easily. And that is where the ethical framework of the state comes in terms of planning universal healthcare. If I quickly shift to the community, I will be saying much of it what Vandana has said already, that in the community, it's not just the identity cards. Even if you have identity cards, even if the resource poor people with psychosocial disability have identity cards, they have been deprived from the rationing process. And it is so difficult to negotiate the 5 windows to access ration. And when we spoke to the BDOs, to the panchayat leaders, they said, come on, ma'am, let us first attend to those who are abled and who are doing dharna here. We will think of the mad people later. So that attitude itself speaks about institutional discrimination and how we look at the larger population with psychosocial disability. The other thing that we have noticed that with uh, earlier pandemics, maybe there was a collective effort, compassion and empathy to deal with each other. But in this pandemic, I definitely see that it is up to the individual whether you stay safe or whether you do not stay safe. What Anjali has been doing in mental hospital is, of course, to provide PPE kits, to do dissemination, to give out information, to make sure that there is running water, to make sure the food is there, because they got chicken 4 times 3 consecutive days because people couldn't go out and buy vegetables. Some people actually ate up sanitizer thinking it was a chutney. And it is because the information was not disseminated properly. So we had to make sure that everything was properly done and supervised and monitored by us. And we also saw how psychiatrists were marginalized in this pandemic, actually, because while the resources were completely diverted, state diverted the resources to the COVID hospital, and quite okay with that. But that doesn't mean that you deprive the mental hospital and the personals there from what they should get. They were actually pulling off the nursing staff and the psychiatrist, and of course we put up a very strong resistance and made sure that they stayed in the mental hospital, because otherwise we would be normalizing dehumanization once again. Till now, we have been able to distribute ration to about 5,000 people. And you have to remember the reality of West Bengal, where we went through a second pandemic in terms of a natural disaster called Amphan. And many of our integrated participants who were living in the community were homeless. So we had to provide financial support to sort of reconstruct their houses. And we made sure that there were about 484 people who were given support. And the last point that I want to make and conclude and come back for discussion is, what is our thought about the bodies which are disposable? Because we interact a lot with queer people and transgender people. In fact, we are doing a study on the mental health of transgenders in West Bengal, and they are in an absolutely distressing condition because they're homebound, they cannot talk about their identity, and therefore the mental health conditions has exacerbated. And the other thing perhaps we need to bring into our discussion is the ethicality of how state is formulating its policies to take care of the marginalized people.
Thank you. Thank you, Ratna. Thank you for all those uncomfortable questions. We'll come back. We'll come back to these for the discussion. May I invite the...
have a minute. Alok, do I have a minute?
Many minutes, Ratna. We'll come back to those.
Okay.
Lots of time. We are well in time. May I invite now Dr. Pratima Murthy from NIMHANS, to talk about the other institution, the institution of the state mental health coping. How has NIMHANS dealt with the the specter of the pandemic in the last few months?
Thanks, Alok, and good evening to everybody. I'll just start off with the first part, which talked about colonization, and I think from colonization, I'm going to talk about the universal experience of coronization. Whether it's from Wuhan to Washington, I think what we've seen is a different phases of the pandemic. So I thought I'll just talk of the phases of the pandemic and the faces of the pandemic in the next few minutes. So I think, those of us who read about Thomas Friedman's It's a Flat World, know that the world has almost been flattened in various ways by the coronavirus. I remember thinking that while the Western world, there is increased longevity and so on, these specters that you saw on TV of people who are above the age of 80 being denied, ventilatory support, it was a complete topsy-turvy situation of what we expect in terms of quality of life and longevity. So life expectancy becomes a disadvantage rather than something to kind of talk about and celebrate. Similarly, we've all known the importance of meaningful face-to-face interactions. And during the COVID epidemic, social connectedness actually became a vice. And online connectedness, which we thought was not a very good thing, became a virtue. Similarly, I think the whole dialogue about masks and what kind of masks and what kind of PPEs, Ratnaboli was referring to that, and these have kind of dominated the discussion, particularly in medical settings. So I think in the first phase of the burnout, all of us, and I'm just talking about the universality of the experience what is called a readiness burnout. We had doubts about getting corona, fears about getting corona, which continue in this phase as well. We had doubts about our preparedness for it, fears about how urgently people would respond to it, and of course the information overload that was very, very obvious, on television. And I have to mention, as a medical professional, I will take 30 seconds to actually read out a poem that my husband, who's a pulmonologist, wrote, which I think really is very evocative of what a medical person feels. I'm on the outside looking in while the young act and fall. I'm reading, advising, pontificating, that is all. Virtually I empathize, vicariously I palpitate. Others struggle for breath and earn their crown fate. I'm just an armchair general planning battles in an iCloud, digitally following through eye-hearse of a warrior in an ice shroud. I spy on a COVID ward while I stand at the gate. I console myself, Milton-like. I too serve while I wait. So for those of us, many of us have not been able to do the work that we can, actually see our patients face to face. And it's quite a distressing thing for clinicians who work with patients all their lives. In our institution, a large part of the first phase was spent reorganizing services, particularly our emergency services, considering the outpatient had to be closed for a little while. A lot of the patients landed up in the emergency, so we had to really rework the emergency. There were a lot of panic reactions amongst our residents, amongst our staff, much less among patients. It was much more among the staff and our own people. We had to negotiate for services, and whether it was safe services for patients who did not have COVID or for patients who were suspected COVID, the large preoccupation with various kinds of protocols. What we did in the institute finally was to actually divide the institute into a red zone, which had patients with COVID who had to be held, an orange zone where hundreds of patients who had to be kept with a suspicion of COVID had to be kept while the tests came, and the green zone where most of our patients who had no COVID were kept. We had experiences of our patient zero. I remember a middle-aged woman, and that was really the very, very few cases of transmission of infection from patients to our staff. It was really the staff who brought in the infection into the hospital. And that's another issue that we need to talk about, because when you actually explored the living conditions of many of our staff, you found that they themselves were living in crowded situations, with very little ability to to keep distancing from each other and to maintain the safety that we talk about subsequently. In our closed wards, especially in our women's wards, there was always a fear of COVID actually coming in. And one of the things that we did was what is called reverse quarantining, which is taking care of our elderly and patients with physical illness so that they would not be exposed to COVID. We were not so lucky in our male ward because one of our staff, who was also doing the barber duties, he had turned COVID positive, and 9 of our patients also turned positive. So I think that was a real, in some ways, a test of our services of whether we would be able to contain that. And I think with the great involvement, with the very active involvement of our residents who were continuously monitoring these patients, and of course, the other staff, we were able to contain the COVID infection to these patients without spreading to the others. The other thing that we did for patients who were not able to access in outpatient services was to provide a continuum of care, because at least through telephones, we were able to contact many of our patients who were in touch with us, advise them about how to get medications locally, how to deal with certain other stresses that they had. In Bangalore, we were able to provide some medication to the BBMP hospital so that they could in turn dispense it to patients living nearby who were in lockdown. The other thing, of course, was to keep the morale of our residents high. And that's been quite a challenge because, every one of them, they're people from all over the country. And we have a student welfare team. We tried to look at their talent, organizing something called Kuch Corona, where they could actually tell us about their talents and so on. We've now come to phase 3, which is possibly the phase of new normalization, I don't know what it is, which is a more pragmatic way of looking at things. Of course, in Bangalore, we are still in the thick of the COVID infections. But I think I'd like to take the words of a colleague who said, sometimes normalcy is, underrated. And I think all of us want to kind of come back to the normal. In terms of addiction, which I kind of deal with as my primary area of clinical work, we've actually seen a lot of effects of the lockdown on the addiction-related patterns. Once the lockdown occurred, our patients, this has not happened for the first time. Earlier during elections, we used to have bans on alcohol. So the election bans caused a lot of alcohol bans, and many of our patients would come with severe withdrawal in casualty. And we've noticed a similar thing happening now in the face of the COVID, that many of our patients were unprepared, had severe alcohol withdrawal, and came with a lot of complications to our outpatients. Vandana already mentioned suicides, and I just like to re-emphasize that loneliness and suicide is kind of almost across the board. And this condition is also likely to widen the treatment gap for psychiatric services, which we already have in our country. In our tobacco quit line, on the other hand, there were fewer callers, but more people willing to quit because, I think they realized that this was an opportunity to address their health. Finally, in the next phase of the pandemic, COVID might eventually disappear. It will leave behind a trail of death, despair, and of course, as we talked about, possibly widen the inequities that have already been there. The fluidity of memory and the capacity to forget is perhaps the most haunting trait of our species. As history confirms, and according to anthropologist Wade Davis, it allows us to come in terms with any degree of social, moral, or environmental degradation. Of course, on a more optimistic note, I just hope it increases our ability to empathize with the other, to be more humane in the way we look at, making inequitability and the kind of, lack of services to the marginalized a little less. I'm just hoping the human within will awaken as the pandemic subsides. Thank you very much.
Thank you, Pratima. Thank you very much. So, all the speakers have spoken about the difficulties and how there is a normalization of the abnormal. There is a normalization of deprivation. There is a normalization of lockdown. There is a normalization of ableism, of ageism. There is a normalization of disposability, of discrimination. And the messages are chilling. The messages are bleak. They are desolate. They are, as we started with, a widening of the existing fault lines. The enduring image of the pandemic is going to be sights of those migrant workers trudging across the country. Who's ever going to forget the chapatis on the railway tracks? None of us. They are burnt into our consciousness, and they will remain. What I want to ask all the speakers is, are there not equally stories of resilience, of coping, of many extraordinary things being done as well? Are Anjali, the Banyan, Nimhans, in small but real ways, not exemplars of this as well? Ratna, you wanted a minute? This is your turn.
I remember an offline conversation with Dr. Jain and you, perhaps after a conference that Vandana had organized, where Dr. Jain very specifically told me that why do we overrate resilience? And why is I was thinking of that. The thing is that I think this is also a moment, Alok, to come to terms with our vulnerabilities. Of course, we are resilient, but that resilience can be demonstrated when we have a strong community feeling. You know, when we work in the community, we see that during death or during marriage, people from the community come together because most of them are poverty stricken. And we see a certain kind of resilience. But when the single most public health message is that you have to take care of yourself and you have to maintain distance, it is very, very difficult. And there is also a limit to test your resilience. But just if I may have 30 seconds, Alok, I just want to also bring in the discourse of touch, the hunger related to touch, and how we have also taken the opportunity to talk about consent and bodily autonomy in institution, which was completely unheard of. Because there is a lot of touch there were a lot of touches in terms of aggression, in terms of self-pleasuring, in terms of intimacy, but how that has also changed, and that how has not been internalized by the people living in institutions. So yeah, I think while resilience is important, we also have to come to terms and acknowledge our vulnerabilities, even as activists, even as social workers, to push our boundaries of resilience. And I remember what Dr. Jain said. Why do we overrate resilience? Why do we need to have resilient communities?
Sanjeev,
Can I come in?
why do we need to have resilient communities? Indeed.
Because for example, you're talking about the plus points. Now, for a virus to appear in December, to have the genome sequenced by January, to have details about how to manage it and all the various complications by February and March, to have protocols for its management, and work on 6 parallel vaccines by August is unprecedented. I think the scientific community is facing a waterfall of scientific reports. There are so many that the journals can't present them. There have been more than 100,000 papers published on various aspects of COVID in the last few months. So if that is not concerted community activity, what is? The problem is when there is a gap between the science and the capacities and the social understanding and the politics, that's what creates a problem. As you saw in places like America versus New Zealand versus Australia versus India. So the public, see, scientists or technology is as much a part of the community as anything else. And it's the communitarian application of science, and who controls the science and who controls the language of science also becomes a community social issue. And it's there that all these fault lines come up. When you start dealing with the illness as some kind of a curse or a metaphor for isolation, for forcing people into the margins, without saying, it's after all just a virus. We've been living together. Fever started long ago, as the song says. So fever has always been with us. There's no need for us to really be panic stricken or about a fever. We will manage, but that resilience is very important to emphasize. And I think, for an example, NIMHANS is testing some 5,000 samples a day for the last 6 months. Labs have been set up. 64 labs have been set up in Karnataka to do the testing. That's the technology aspect. Do people get their results on time? Are they explained what it means? Do they understand how these things are done? What is being done? It's not just a magic box. It's just a simple science. So unless you understand and share that science, these kinds of difficulties in transmitting what resilience is becomes difficult, because resilience has to be understood that these are the bricks we are putting in to make ourselves resilient. It's not a magic wand that we are waving that will import some kits and will import some ventilators and everything will be fine. That's not resilience.
So I think the message of resilience is far more complicated and nuanced than perhaps what is understood. And I don't think that that any community, including the scientific community, has covered itself with too much glory in the past few months. The sheer number of publications is both mind-boggling and confusing and perhaps often contradictory. So the making sense of it is, I think, where the answers will lie. Which brings us back to the message. What is it that we are trying to communicate? Are those messages in themselves discriminatory? Do they fan the inequity? Do they?
Yes, they do.
What is it that we need to think about as far as that messaging or that primary communication? Vandana, any thoughts?
So I agree that, like Sanjeev said, that there's been a lot of work in the scientific field. I agree with Ratnaboli when she talks about the community not having come together. But to respond to your question about NIMHANS, Anjali, or the Banyan being exemplars, I think there are many others.
Of course.
And I feel that the community, sure, maybe in Ratnaboli's case or in a few other cases, hasn't come together the way that we'd like it to. But in many other cases, it has. Now, the point is that will it sustain? So I have a quick, and that's exactly what Sanjeev said at the beginning, right? So two of the homeless men that we met on the streets were people who ended up homeless post the tsunami. Now, when was the tsunami? It was in 2005. It It's been 15 years. So every time that there is a tsunami, every time that there is a pandemic, every time that there are the Chennai floods, every time that there is a whatever else, a hurricane, a typhoon, there is a response. And maybe people gather because you're driven by emotion. And that's good. But what happens after? And that's why I mentioned the normalization of deprivation. So we believe that at a point like this, it's important and imperative that we step out of our comfort zones and extend a helping hand, sure, for the person, because we feel greater empathy, maybe, and active empathy, but also in a sense for ourselves, because we feel good doing what we are in a situation of crisis. But in an otherwise unequal world, where we are the privileged, and where even the scientific community, for that matter, while we talk about all the papers, how much of the papers actually translate to bridge these inequities? The 80% of the living below the $2 has not changed with all the science in the world. The homeless persons and the number globally and in India is on the rise all the time, despite millions of papers and numbers of models that we are saying can be taken to scale, right? So what is going wrong? Is it the society? Is it the state? With the state, again, I'd say there have been positives and challenges. Now, for the homeless, for example, for every 1 lakh, you're supposed to have an NULM shelter, right? But how are these shelters? In these shelters, do you have the opportunity to isolate? Can you maintain physical distancing? Do you have access to basic amenities? So I would think going beyond the discourse of resilience and stepping into hope. And this is where I draw from what I said about the kids. They're exposed to domestic violence. They're hugely exposed to financial difficulties. They're transitioning to a new world of online education, and yet they're hopeful. So hope seems like a soft term, but typically in hope studies, when you deconstruct it, very quickly I'll end with this, there are two pathways. One is hope typically means that you feel that you're in control of your life and control of your future. And therefore you set goals, whatever the goals may be. It could be not to be resilient, to sleep at home, or to change the world. Two is that you find pathways to make sure that you're able to meet those goals. So hope deconstructed is this. And maybe resilience or grit or whatever else is a part of that. But I feel for us to be hopeful, our majority has to know that they are in control of their lives and that there are others who will challenge these inequities to make sure that we're on a level playing field and that more people have control of their lives. So they're able to find their own pathways. They don't need Anjali or Nimhans or us or Sanjeev or the papers or you.
I have a quick intervention to make, Alok, very quick.
Absolutely.
Well, of course, we all operate on hope, and hope is like a mustard seed. But in the outer world, the mental health discourse is constantly focusing on toxic positivity. And somewhere hope and toxic positivity is getting conflated. And that, I think, is a very, very problematic critical zone, because now everybody has to be hopeful, everybody has to be positive, everyone has to learn cooking skills, everyone has to be nice, everyone has to do online classes, they'll have to do n number of webinars. And this whole concentration on the positivity part is making me depressed, making me extremely, alone, because I don't want to participate. I feel it is okay if I have not learned baking like you have, Alok.
Like I've learned baking.
Yes, you have learned baking. In this pandemic, I think it's okay if you don't learn anything. We have to maintain a balance between toxic positivity and hope. That's the point I'm trying to make.
Which is why I wasn't referring to hope as a feeling that is uplifting, right? I broke it down and deconstructed it to say that I have some control over my life. And I can find pathways to do whatever, to not bake, to sleep, to work, to do whatever. And they don't have to be binaries, right? So I'm deconstructing hope, because hope otherwise is understood as only a positive emotion, right? And I feel concerned when we use, I feel that this whole phrase toxic is something that I don't know where it sort of appeared from, but that's for another conversation. But I just feel that it's important for people to feel in control of their lives, that they don't. And because they're as deprived as they are, that's when there is the propensity for them to feel completely pushed against the corner and to feel that there are no solutions. And like in the case of one of the women whom we cared for, decide that there was no point in living and die by suicide.
So just to set the record straight, I haven't actually learned baking yet. I may in another world, but that's a different story. The issue of desolation, the issue of how bleak vistas have been uncovered by the pandemic, I don't think is in doubt. The fact that powerful stories of those discriminations and deprivations exist, and the fact that a lot of counter stories of many things that are being done as well. The reason for bringing up Anjali and the Banyan is that endeavors which started with difficulty, in the facing of difficulty, and continue in various versions and avatars, can themselves be exemplars of this. I don't think we should have any doubt about. And the fact that there can be no one narrative of what it is that is ideal or necessary or the way that things should go, again, I don't think any of us have any doubt about. The fact that social connectedness or the lack of social connectedness is one of the factors which has made this pandemic so much more virulent in a sense, is again abundantly obvious. And exploring, unpacking, or trying to figure out those possible futures is perhaps one thing that is in many ways incumbent upon us, without, how should I say, without silver lining any of these issues. But I think that is perhaps what we all need to think about. We're going to also look at some of the audience questions that have come about. Okay. One of the questions is, what is the advice for seniors, especially professionals? Pratima, you think
It just says, what is the advice to seniors?
Advice for seniors, especially professionals.
Yeah. So, I mean, I think there are two aspects of it. I mean, whether we like it or not, this is a virus, this is a serious infection. And although many young people, many able people are able to get away irrespective of their socioeconomic status, etc., with a mild flu, the elderly are much more vulnerable. So I think it's very important to be safe. And I explained the concept of reverse quarantining. But at the same time, I think the biggest challenge is to stay connected. And I think the importance of social connectedness, especially for older people, is very, very important. I think for professionals especially, I think this kind of connectivity and sharing of knowledge and experience, through technology. I mean, one of the things, of course, now is really to exploit technology and try to stay connected and use the skills. I think it's very, very important to stay professionally active, because, the more you do, the more, attentive you are, the more, positive you will feel. So I think that's very important. I just wonder if this is one time where we can look at older professionals to really examine some of these inequities in society and really see how, as a system, I mean, the coronavirus is not going to stay here forever, but humanity is. So in terms of actually looking at these disconnects, whether something can emerge. I don't agree with what Sanjeev said. I think it's a case of the emperor has the emperor's new clothes, because I don't think science has greatly progressed. The virus will run its natural course and then
die. Lovely. Another question, which is...
But we'll know when it is run its course.
Any astrologer will tell us that. Can we think of a nationwide socio-mental reorientation program, especially for those who are facing extreme financial distress?
Basic income. It's worked so well in many countries. And there was a huge push in that direction a while ago in India. I don't know what's happened now. But basic income for sure. Because I don't think, I agree that social security schemes are good and that they're required, that health and education are public goods. But I think people should have access. Again, this is a question of control. If you have money in your hand, you choose how to spend it versus being on a dole. So I would think basic income is really the way to go. And there are lots of examples world over with RCTs, case studies, where basic income has actually dealt with several other disadvantages and resulted in gender parity and a whole lot of other inequities and social injustices have been dealt with. So we should really push for basic income. That way, even if you're out of job, for example, several workforce participation, especially amongst women, right, is very low. Again, workforce participation amongst those with disabilities is perhaps the lowest. The poorest in the world are those with disabilities, according to the World Bank report. So if you have the poorest is those living with disabilities, if you have women out of the workforce, if people opt not to work, there should be some way in which there is a basic income and that they don't have to feel dependent and feel that their sense of autonomy and agency is taken away on account of money. Me, for example. Right?
I think we have to... That's a challenge. Go ahead.
Sorry, Pratima?
I was just saying, and right now I think that's one of the biggest challenges, because there are a lot of people who were actually moving up somewhat in the economic ladder are again falling behind. And I think that is going to be something that's really going to be a challenge.
And this will settle back for a long time.
I personally think that state has to be made accountable for the promises that it has made for all the people, including the marginalized, because the number of schemes that were announced just after the lockdown, none of it has been followed up. And we as citizens have been just bystanders except a handful. Why aren't we demanding accountability, implementation of those schemes?
I just want to quickly add that in Tamil Nadu, the schemes, the $1,000, I know that it's perhaps not worked in several other states and you have a lot of experience that part of the country. In Tamil Nadu and Kerala, our clients, that's about 1 million low-income households that we service, they've all gotten their $1,000 several times, and that's been extended. They've gotten their dry rations. Unfortunately, they haven't managed access to vegetables, but because of the $1,000, they managed to buy some. Or the backlog of the disability allowance, which was on hold for a long time. They used this as an opportunity that the disability sector lobbied hard, and they got that as well. So I'm not saying this is a favor, but I'm just giving you the other side as well. This is not the majority.
Maharashtra, for example, Maharashtra has not done well at all. It is a question how, as a nation, we progress to bridge the inequities. And it is not one West Bengal, it's not one Tamil Nadu. It has to be the entire country. We were promised 500 rupees from the state government. Some have received, some have not. Now, someone has to do these follow-ups to make sure that money reaches these people.
I don't think that there will be any argument about that, Ratna. The fact that guidelines vary, the fact that we have not learned from one state to the other, the fact that there has to be a uniformity of measure, of messaging, about the fact that that messaging and that measure has to keep in mind social equity at all times is abundantly obvious, and the fact that it has not been as much as required, I don't think any of us would have any doubt. And I think it is incumbent upon all of us to work to make sure that this continues. There is another number of questions.
Can I just make one comment?
Yes, Sanjeev.
Perhaps like the old thing, never let a crisis go to waste. This is the time to actually think of a national health service kind of thing and create a notion that health and health provisioning is a public commons, to create that public commons instead of thinking of it always in splinter terms of one program, this program and that program. Yeah. This is the time to think of a uniform, accessible, equitable healthcare system.
Absolutely.
So the fact that like all challenges, that this is an opportunity as well, is obvious. And if there is a possible way forward, then these might be.
Absolutely. China changed its entire healthcare after the SARS epidemic.
Yeah.
That entire technology which they could bring into play on this was only because of the SARS epidemic 10 years ago. They changed their entire healthcare system from barefoot doctors to completely different managerial, technocratic healthcare in 10 years. For that simple reason, because of the SARS epidemic. It's time we learned something along those lines.
Sure. So there may be things that we can learn from China as well. There's a whole series of questions here which are to do with telecounseling, about who is it that is accessing the telecounseling. Will it play a role? Will it play more of a role? And in days to come, what do we see as the space of telecounseling and teleconsultation? Pratima, would you want to?
Teleconsultation, the use of digital technology to reach people is not a COVID phenomenon. It had actually started, at least in the last decade or so, as a very powerful way of actually training people, particularly in remote, underserved areas who don't have access to healthcare, in terms of training several kinds of health professionals to deliver care in the primary healthcare settings. And of course, making sure that this is not just in mental health, it's across the board in several other areas. It's been demonstrated in liver diseases and cancers and so on, because by the time people actually are able to reach tertiary care, it's often too late and they're never able to. Right now, the COVID has provided an opportunity for actually increasing the use of this modality, because people cannot reach hospitals. So I think it has immense potential in actually being able to make sure that people, wherever they are at least, if they are stable, continue to be, receive some form of counseling rather than complete kind of neglect. In future, I don't see it as replacing human interactions, but I think certainly in terms of staying connected, I think it's going to play an important role in the future. But just as we speak, I mean, we had, it's not just the technology answers everything. At the moment, somebody digs up the road and your phone lines are gone. So I think even that requires a lot of looking after and nurturing and expanding.
There's a question here which says, what sort of role enhancement of mental health services do we foresee now, and how optimistic can we be about it? So,
I have a comment.
Yeah.
I have a comment.
Absolutely.
So, I think we should, all this, I mean, it's clearly evidenced now that mental ill health has an impact on your quality of life, on poverty, and vice versa. So it's bidirectional, right?
Absolutely.
For the longest time, I was under the impression, but I'm now giving the whole discourse a rethought. I was under the impression that as part of mental health interventions, we focus sure on the causal pathways, early identification, referral pathways, treatment, social inclusion, and whatever else, and personal recovery. Right? Now, I am beginning to wonder if this should be interrelated but distinct. So there is significant focus on the biomedical and the rehabilitation, the social inclusion parts as part of the clinical piece. But that, what we discussed earlier, the push for basic income, the push for all the SDGs, whether it's poverty reduction, zero hunger, inclusive communities, gender parity, they should be two independent conversations. Because I feel, unfortunately, now, somehow the two are getting mixed. So I would think that the way in which I see mental health spin off is sure, because mental health encompasses everything. And therefore, I would think that the conversation has to be around everything, but divided into distinct spaces. And therefore, you bring in human service professionals where required, and bring in psychiatrists and others where required. And the two talk to each other, but don't just make it one big blob. And that's what's happening, unfortunately, now. So people like Ratna and I, for example, can contribute significantly in the social spaces as much as we can in the clinical, but more so in the social, right? And there are several people who can contribute significantly in the biomedical space. So let the two speak to each other, but there needs to be an equal thrust in each. And that is not happening now because of this, a large number of studies also showing that there is this bidirectional impact. So I would think, and therefore people are not accessing care soon enough. So there's two different conversations. I mean,
absolutely. So the fact that the bidirectional thrust or the bidirectional influence, I don't think that anybody would have any doubt about. Is the possibility of splitting those conversations and splitting those discourses not by itself invitation to binary thinking, which is where the problem starts from?
So, which is why Alok says, I said I was, giving this a rethink, because we often talk about intersectoral coordination, and there is a need for coordination. And like I said, social is a part of mental health, and mental health is a part of social. Now, you can decide which is the larger and which is the smaller based on your orientation or the lens that you use. But in the process of doing this, things
why does it have to be either?
It can be both. But the problem is, if it is both, there have to be people who advocate for change in each of these spaces. So we don't have enough advocates. We don't have enough people who are driving for the sort of change that we want to see. And therefore, I would think it would make greater sense to
have those advocates.
to have more advocates, but also to have greater change in the social space, whether it is public institutions, the way in which mental hospitals operate, long-term care over an extended period of time. We've seen that, right? Health is both a state and a central subject, and we've seen how it operates differently in each space. Similarly, social welfare. And therefore, if you are a person with disability, mental illness, and as a result with disability, you have to access your disability allowance from the social welfare department or from the disability department. Now, this intersectoral coordination is not happening. And there isn't sufficient push. Similarly, people with long-term needs, they're either in hospitals or there are the rehab homes. There's nothing in between, and it's no man's land, really.
Yeah.
I think, Alok, very quickly to add on to what Vandana said, while it's important to have a discussion in the social space, but I think it's also time for mental health professionals to look at the social dimensions. And maybe, it's not up to the advocates like us, because we are also my way, highway types. So people.
I would never have thought that, Ratna.
No, but let's be real. I mean, we are also to an extent my way or the highway type. But the point is that if the psychiatrist and the mental health professionals start looking at an issue which is not just as a brain biology issue, but also as a social issue, and if the messaging is intersectional and multi-layered, then people will respond to it also differently. Because the way Vandana is saying, I completely agree with her. But it is the advocates and activists who are pushing the discourse in one way, and the mental health professionals like you pulling the direction in another way. So why not look at depression also as a gender issue? Why not look at depression as an economic issue? Why wouldn't the mental health professionals be political?
Yeah, absolutely, Ratna. That has been our push and direction all the while. I think it's established without a trace of doubt that gender inequities, poverty, deprivation all have an impact. So I'm saying now that it's established beyond a trace of doubt, how is it that we can roll it out in such a way in which the implementation is such that it betters the quality of life? So I'm not so much talking about the orientation of a psychiatrist versus that of an advocate. I think that orientation has to be uniform, alike, accepted, where we embrace the biomedical, and people like Alok, Sanjeev, Pratima very much embrace the social, and I'm sure there are many others who do that as well. So there is common understanding, and there is common causality, there's common implications. We understand it, but in terms of its translation in the real world, in the messiness of the real world, so maybe I didn't articulate myself effectively enough. I feel that in the translation in the real world, while we work as one cohesive force, it needs to be a significant segment, and it could be, again, an Alok, a Sanjeev, a Pratima, a Ratna, or a Vandana in either of the spaces. It doesn't matter. But there needs to be determined focus effort towards basic income, universalization of healthcare, gender parity, housing stability. And these are issues that sure impact mental ill health and vice versa, but also are standalone issues.
Pratima, what do you think?
I was taking out from there. I was just wondering if it should be a khichdi, since we were talking a lot of food idioms in the beginning, whether it should be a khichdi or whether it should be a paratha with aloo. So I mean, I think there are benefits and merits of both, keeping things distant. For example, in the area of mental health, there is a great need to integrate mental health with physical health and well-being, because we know multimorbidities have worse outcomes. But at the same time, unless you advocate for mental health, the mental health space is likely to get neglected. So I think there are advantages and disadvantages of both these. But I think by and large, I think the need to look at the whole thing in an ecological manner rather than just in isolation, I think is a very, very important thing for all of us. As you know, in conclusion, what I'd like to say, Alok, is again something that I heard, is like we're like in an ocean of corona at the moment. All of us are in boats, but various kinds of boats in this large ocean. But I think what we need to remember is there are people who don't have these boats.
Yeah.
And I think it's really about giving them some kind of mooring so that they are able to come off it effectively. And I think it's not just health, it's the economics, it's a larger connectedness that needs to be also looked at in this process. Thanks.
I think, Pratima, that is extremely well put. I don't think that any closing remarks can match up to what you have so eloquently expressed. And I think all of us are in complete agreement with this. Coming from diverse spaces with lots of things in common and lots of things which are different, the need for finding those commonalities and working with those has perhaps never been as important as it is now. And I think that it is incumbent upon all of us to find those common spaces and work with them. And despite the truly extraordinariness of these times and the bleakness and desolation and despair that surrounds us, to hopefully find our ways through. So thank you all for a very stimulating, occasionally confrontative, always exciting conversation. Thank you to the India International Center for hosting this. I think we've gone way beyond our time, but I look forward to many, many more conversations. Thank you all. Thank you to the audience, which, as Ratna said, while being invisible, has, obviously been participative, because I can see again a whole series of questions which we haven't even, and they're really large. And in fact, I now see a whole new series of questions as well. So maybe we will invite the India International Center to invite us for a future discussion, for a continuation of the discussion.
No, we can try and answer some of them offline without extending our
we can try that as well.
Patience beyond.
So thank you very much, and we'll try and answer some of these questions offline. Thank you so much.
Thanks a lot,
Thank
Alok.
you.
Thank you.
Thank you very much. Thank you.
Wonderful.
Thank you.
Thank you so much.